also just want to express my appreciation for the invitation to be part of this lecture series, along with others, again, in the chat, just looking at some of those prior speakers that you've had and topics that you've had, really a rich tradition that you have as part of this Bulls Chapel lecture series. And honestly, just honored and humbled to be a part of it. As I was reflecting on the title that I assigned to this talk for today, or the subtitle "From Combat to COVID-19," Brent and I were first talking back this summer about the possibility of participating in this lecture series, and there was sort of this little sweet moment in time. I don't know if folks can even recall that or not now, but there was this point in the middle of this past summer where we kind of thought, oh, I think we're sort of done with this pandemic now. Our numbers are really down and the cases are down and all of that, and people started to travel again. And the only bit of work travel that I've done in the past 2 years was a little bit of travel where Brent and I saw each other, and we were talking about this and thought, I think we'll maybe be able to be in person come January. And of course, then September came and the wave, and of course now there's the wave that we're in now. And the most cases that we've seen, and I don't need to tell those of you who are actively in healthcare context right now what COVID-19 means to our healthcare systems and how overwhelmed we continue to be by this pandemic. For those of you who remember 9/11, a lot of the research that I'll be talking about today with respect to moral injury has been done with post 9/11 veterans. The construct and the idea of moral injury as we've studied it and developed it in recent years has really come after that event on September 11, 2001. When that happened, I think there were very few of us who thought we're on the cusp of our nation's longest wars. As specifically, the conflict in Afghanistan is technically our nation's longest conflict, longer even than the war in Vietnam. In some ways, I think when we look back 2 years ago now, and we think about the pandemic sort of first beginning, there were very few of us, I imagine, who thought we would find ourselves in the place that we're in now 2 years later. I was talking with a research assistant that we have here in our program just yesterday, and first I was asking her a bit about her memory of September 11, and she was 3 years old then, so not much memory of that. But she was taught, she was an undergrad, and said at Duke, and was saying, when the pandemic first started, they kind of said, oh, this will just be a week, we're just going to go virtual for a week. And all the different messaging that so many of us received at that time and thought it was going to be, a relatively short-lived thing, and it's turned out to be anything but. And I think, when we think about concepts like resilience or like moral injury, the length of these things can really begin to have a toll on us. So, as I mentioned, a lot of what I'll be speaking about today is about research that's been done with veteran and military populations, because that's a lot of where this construct of moral injury has been developed. In the second part of today, I will get to talking a bit about moral injury in relation to healthcare workers, and a little bit of data and research by others as well as our team in this area. But I trust as I talk about the research and interventions and ideas with veterans that those of you in healthcare context can hear that and can be thinking about some of the applicability to contexts that you may find yourselves in as healthcare workers. So as Brent mentioned, we will have kind of two sessions today. So we'll have a break around 10 o'clock Central Time. I'm on Eastern Time, so I need to make sure that I'm looking at the clock correctly. So 10 o'clock Central Time, we'll have about a 15-minute break. And you can see I've provided some kind of subtitles to the two sections of our morning. So with the first part of our time together, I want to be looking at moral injury indications and iterations. My apologies for getting a little carried away with the alliterations on this slide, but I do actually mean things by all these I words. So I want to begin at some point this morning talking about kind of preliminary indications of moral injury, things that we were seeing, especially among veteran populations, even before we started to use the language of moral injury. And then after that, we'll talk some about kind of this idea of iterations, or how are we defining moral injury? What are we saying it is? What are other people saying it is? What are different groups hearing when they hear that terminology of moral injury? And how do they interpret that? So that's a bit of what I mean when I say iterations there. And then after the break, we'll get into identification of moral injury, specifically with some focus on measurement and different findings that have come out of some of those studies using different measures. And then finally, we'll finish our time looking at different approaches to intervention. And a lot of these approaches are quite new, so I'll point you towards some different resources and things, but there's a lot of development still going on with respect to different interventions for moral injury. Throughout our time, to start the day here in a moment, and then in our second session, very near the end of our time together today, wanted to incorporate a couple of different exercises that will be inviting you into kind of some of the space, hopefully, that Sandra was alluding to with kind of her opening invocation, some mindfulness exercises and some things that touch on aspects potentially of moral injury, or even ways that we might think of intervening for folks who may have had morally injurious experiences. So we'll have those, and then we'll also have a couple different places for Q&A, one at the end of this first session, and then another one during our second session. So when we come up on those, I'll kind of let folks know about that. I recognize when we're in these virtual environments that some of that interactivity and things can be a little challenging, but within the confines of this being a webinar, I've tried to make some space for some different experiences today. So before I get into that kind of opening exercise and reflection that I was just alluding to, I do want to note that much of what I will be talking about today is really the result of lots and lots of collaborations with excellent colleagues that I've been privileged to work with over the years. And I won't go through everybody who's on this list here, but I do want to name Dr. Keith Metter, who is the director of Integrative Mental Health and the Department of Veterans Affairs, the program I work with, and is also at Vanderbilt University, and has really been a close partner for over a decade in a lot of the work that I've been a part of on moral injury. Have also, largely as part of that program within VA, I've had the opportunity and privilege to work with a lot of chaplains over the years. Much of the work that I do on the VA side looks at ways of intentionally integrating chaplain and mental health services. And we've done that in lots of different ways. And one of the key areas that we've focused on in recent years has been in this domain of moral injury. And I'll talk some about that near the end of our time together today. And that's just been enjoyable work for many different reasons, but also rich work to have different disciplines, different perspectives, especially on this topic of moral injury, being brought to the table. So I have some chaplains listed there. I know that Chaplain Keith Etheridge is also, I saw your name in the participants today, former director of the National Chaplains Center for the Department of Veterans Affairs, was really a key colleague for many years in much of this work as well. So I'll stop naming people before I lose all the time to that, but do want to make sure to note that the work that I'm talking about really reflects efforts of a lot of wonderful colleagues across systems that I've been able to work in. Before I get into kind of describing moral injury and talking about some of the preliminary indications and those sorts of things, I do really want to acknowledge that for many of us and for many of you on the webinar today, that some of these topics and things that I'll be talking about may resonate on a personal level as well. The pandemic has been going on for a long time, and we are all quite well aware of the difficulties and struggles faced, especially by healthcare workers during this time. And I offer this picture here because the exercise that I'm going to kind of invite us to participate in together is inviting us to attempt to kind of see one another. I know that we're in a virtual environment on a webinar. I recognize that some of you may be in settings where you have something else going on behind you, the dog barking if you're at home, or if you're in a clinical context, you might have people coming in and out of your office or wherever you are. So I recognize that some of these exercises may be a little challenging, but I want to try to hold some of this virtual space together, and I want to take a moment to attempt to sort of see each other, so to speak, and to hold your colleagues, for those of you who are in healthcare contexts, with a sense of appreciation and compassion for the work that you do in the space that many of you find yourselves in right now. So to begin, acknowledging that we're all kind of in different spaces today, I would like to invite you to kind of get comfortable where you're seated. If you're able to sort of put down any distractions for the moment, I'd like to kind of walk through a bit of a mindfulness exercise. And if you could just pay attention for a moment to your breath. I invite you to take a deep breath in and out. And to just settle your attention to this moment in time. As you do that, I invite you to kind of recognize that all of us who are gathered here today on this webinar and the different work that we do and the different ways that many of us are engaged in the healthcare context, that we all have a variety of different motivations for why we do the work that we do, why we do what we do in healthcare. And, of course, there are the things that we could label as kind of external motivations, so to speak. There's the paycheck to keep the lights on. You got mouths to feed, a roof above your head. There's, job to give you something to do. There's just the habit of going in every day, right? There's sort of those external motivation kind of things, but there's also what we might think of, and what I want to invite you to sort of come into contact with and recognize, if you can. There are also those internal motivations for why we do the work that we do, especially for those of you in healthcare, and especially over these past few years. There are probably easier ways to pay the bills and to have a career. There are probably things that would demand less of you than what you've been doing in healthcare, especially again over the past couple of years. But for whatever reason, many of you on this webinar today have chosen professions that involve accompanying people through some really difficult stuff, through very challenging places in their lives. For some of you, you really accompany people through some of the darkest times and places in their lives. Many of you have chosen a career that involves walking with people in some of their greatest frustrations, maybe their deepest despair, moments of pain, deterioration of health, maybe experiences of betrayal, feelings of hopelessness. Maybe as I name some of these things and you think about the work that you do, a certain person or a patient or a client comes to mind for you. As you think about that, I want to turn back to this notion of that internal motivation. See if you can kind of identify within yourself that reason for why you choose to do this work, why you choose to walk with people even through some of these really challenging moments. Why do you do this on kind of an internal level? What's your passion or your heart? And maybe this is something that you're really connected to every day. Maybe it's something that you were connected to at one point and feel less connected to now. I invite you, if you can, to sort of bring that reason to mind, or bring that passion to your mind, and allow yourself to just sort of feel that and connect to it. And if you're able to do that, if you're able to sort of bring that to mind, see if you can sort of extend to yourself a sense of compassion, maybe even a sense of gratitude to yourself for being willing to do the work that you do. Now, what I'd like to invite you to do is to imagine a close colleague of yours. Perhaps it's somebody who's also in attendance today, maybe they're not. If it helps to close your eyes to kind of bring somebody to mind, I invite you to do that. Once you've brought somebody to mind, I invite you, of course, without words, to imagine that you're sharing with this person your reason, your internal motivation, so to speak, for why you do the work you do. And imagine that this person, that they really hear you. They can really listen and can honor your heart and your passion, and that they can really sincerely appreciate, this thing or these things that motivate you. Now, if you can, notice that this person, like you, has their own reasons, their own internal motivations for engaging in the work that they do. And imagine, again, of course, without words, and as you're holding this person in mind, imagine if you could hear from them those reasons and see if you can hold that with a sense of kindness and appreciation and gratitude. I'd like to invite you to bring someone else to mind, somebody else that you work with, maybe somebody you more occasionally interact with. Maybe it's somebody in another department. Take a moment, see if you can bring that person to mind. Kind of hold them in your mind. And again, if you can notice that individual, like you, has their own internal reasons and motivations for engaging in the work that they do. And again, I'd invite you, as you imagine that, to see if you can kind of hold them in your mind with a sense of kindness and appreciation and gratitude. Now I'm going to invite you one more time to bring someone else to mind. Maybe somebody from work who you don't really know well at all. Maybe it's somebody that you just occasionally pass in the hall or you see in other contexts. Maybe it's somebody you see on your way into work in the morning or something like that. Take a moment again, just bring that person to mind. And even though this is a person that you don't know well, you don't know what's going on with them, but you can know that they have full life just like you, with things that are going on, and that they too, like you, have their internal motivations, their reasons for doing the work that they do. And see if you can imagine, even with this person that you don't know that well, kind of extending this sense of kindness and appreciation and gratitude. Now, finally, as you think about some of these things, kind of extending this sense to others and receiving it from them, I invite you to notice too that there are all sorts of things inside you that you haven't shared, different joys and challenges that are in your own life right now, things that others may not know about, maybe even a secret pain that perhaps you're carrying. Just notice that those things are there, even though they're unspoken or other people may not even know about them. And notice, as you imagine these other co-workers that I invited you to bring to mind a moment ago, and as you imagine even the other people on this webinar today, that all of us have those things. We have our own challenges, our own joys, our own sorrows, our own aspirations, our own secrets. And of course, without knowing what those things are for everyone, see if you can extend kind of a sense of compassion to one another for these different things. I want to allow folks just to find a moment to connect with anything that this exercise has brought up for you as you reflect on some of your coworkers and your community. When you're ready, I invite you to just take a deep breath. If you've closed your eyes, I invite you to open your eyes, kind of return your attention to this virtual environment that we're in together today. If you were able to participate in that just now, I want to say thank you for doing that with me. One of the reasons I selected that exercise today as we focus on moral injury is with moral injury, one of the things that can happen, and we'll talk about this more, is there can be a sense of shame, right? Feeling lesser than. And one of the main things that shame can cause us to do sometimes is to isolate, to pull away from other people, to feel, that we're other than, and that we're not good enough to be connected to a community. And so I wanted to walk through this exercise of, even though we're, not actually talking with one another, to recognize other people are holding things too, and we can be and are part of a broader community. At the end of our time today, I want to note this just now, and I'll note it again later. If this webinar or topic is bringing up things that are relevant for you, certainly want to encourage folks to reach out to different resources. And so if you're not able to stay on till the very end today, please think about that now. And if you are able to stay on to the very end, I'll name some of those things at the end today as well. All right, so with the remainder of our time here before the break, we'll be focusing on kind of these couple topics that I mentioned already. First, preliminary indications, and then some of the definitional stuff. So with respect to this topic of indications of moral injury, or kind of preliminary indications, there are lots of different ways that moral injury has existed well before we began labeling it as such within the literature and thinking about it with respect to post 9/11 veterans and different things. The images that you see here are from a National Geographic cover story, actually, that came out a number of years ago, that was looking at the invisible wounds of war. And the term moral injury actually doesn't appear anywhere in this article, but what you can see, if you're able to see the screen here, these are different masks that these combat veterans made, and the masks were intended to represent how these veterans feel on the inside, right? And as you read and heard some of the different stories behind each of these masks, it was very evident that aspects of moral injury were there for a lot of these veterans. So I think these images, are just helpful ways for us to recognize a little bit in line, even with the past exercise that we were doing. We don't know often what our coworkers are going through, or what they're carrying, or what they feel like they might look like on the inside. And this is sort of a helpful visualization to realize, folks are carrying those things. I also think it's neat, some of the different interventions that I'll talk about near the end today are moral injury groups that are co-led by chaplains and mental health professionals that bring in lots of different approaches well beyond kind of traditional psychotherapy. This, of course, would be kind of a form of art therapy, and in some of the groups that chaplains and mental health professionals are doing in VA, different sorts of art or making things or drawing will be incorporated sometimes into the work. And I think there are various ways that moral injury lends itself to thinking a little bit outside, at least for myself as a clinical psychologist, outside of the traditional boxes of psychotherapy. All right, so before I get any further in talking about moral injury, would like to do a poll here. I don't know if Gayla or somebody is able to bring it up. Oh, great, I see it there. So give folks a few minutes or a moment to answer this poll question. How familiar are you personally with the concept of moral injury? Looks like some responses are still coming in, so I'll give it a little more time. Great, and I don't know if other folks can see the poll or if you're able to share that and publish it. Okay, great. I think you're sharing it. So it looks like most folks have heard of it, but not particularly knowledgeable about it. A few of you come today have never heard of it. So we've got about 3/4 or so who've either never heard of it or heard of it, but don't know much about it. And then a few of you who are pretty knowledgeable. So hopefully, those of you who are pretty knowledgeable, I imagine I'll say some things that you already know, but hopefully there's something in here for everybody today. So you can end that poll. Thank you very much. All right, so with respect to this idea of early indications of moral injury, even though in a little bit here I'll be showing you some of the quote unquote seminal publications that date back about a decade or so, obviously, or hopefully this is obvious, this is not an experience that suddenly leapt onto the scene in 2009 when Brett Litz and colleagues started putting this term into the scientific literature. We can go back a long ways throughout recorded human history. What you see on the screen here is a depiction of a scene from a play by Euripides, who is a Greek playwright, wrote the play The Trojan Women nearly 2,500 years ago, so a long time ago, right? This is one of the oldest remaining pieces of Western literature in some ways that we have. And within this play, Euripides is reflecting on the relatively recent Trojan War, and the scene that you see depicted here, it's actually a little bit different in the play. But you see here that the wife of Hector, who's the crown prince of Troy, so this is Andromache, who is in the scene here is witnessing the death of her son. In the play, it's actually a little bit different. You have the Greek soldiers who have just come in and had this battle with the Trojan army, and this Greek soldier who knows that Andromache has just lost her son, that he's been killed in this battle, has to go to her and relay this news, and it's this drawn out struggle that this Greek soldier has of I don't know how to say this. There are no words that can express what has happened, and he's from the opposing army, right? But clearly just this sense of this isn't right that this happened, and I don't know how to say this, right? And throughout this play, in various ways, Euripides is really exploring some of the various um, moral dilemmas and challenges that are inherent to conflict and to war. So this is something that we as human beings, in lots of different ways, and we could go through various other examples, have recognized for some time, of course. Uh, More recently, within the scientific literature and looking at some of our still surviving populations of veterans within the United States, there have been a variety of different indicators that moral injury is something worth paying attention to. So the work that you see here on this slide is from the psychologist Shea McGinn, who's in San Francisco, who has really pioneered doing some work in an area that is relatively taboo, and that's this area of killing. Even within the VA, even among those of us who work with veterans, this can still be a challenging topic sometimes to bring up and to talk about. But the work of Shea McGinn really points to the importance of recognizing how killing in combat situations can have a profound influence on our mental well-being. I should note, for those of you, in a social context, if you're at a cocktail party with a veteran, do not ask, "Did you kill anybody?" That's not an appropriate question to ask in a social situation. Within a clinical context where we're providing some kind of care, providing ongoing pastoral care or psychotherapeutic care, this is an important topic to ask about appropriately and to understand. What Dr. McGinn's found in a lot of her research, she's looked at a host of different populations. You can see she's looked at OIF, OEF veterans. For those of you who are looking at those acronyms and going, what in the world is that? That's Operation Iraqi Freedom, Operation Enduring Freedom. That's really just our post 9/11 veterans who have served after September 11, 2001. So I'll be referencing that population in different ways today, but that's all essentially referring to our most recent veterans. So she's looked at that population. She's looked at Vietnam era veterans. She's looked at Gulf War era veterans, so veterans from the 1990s. And you can see has consistently found that participating in killing as a member of the military is related to a host of different things. So higher PTSD symptomatology, suicidal ideation, depression, alcohol abuse, anger, relationship problems, dissociation, functional impairment, violent behavior, right? Different conglomerations of these different things that she's been able to look at in veterans from different combat eras, but consistently across all of these different eras, seeing that there's something about this experience of killing that is particularly troubling to us, over and above other kinds of traumatic experiences. And I think that's suggestive, and Shea McGinn's been part of a lot of the early research around moral injury as well, because there's something about killing, even within the context of combat, even within contexts where it's sanctioned and there's the rules of engagement and all that, that for many of us, I think, just really goes against our moral code. Other research, some of you may know the name of Kent Drescher, a psychologist who for years was at the National Center for PTSD and has since retired. Did a lot of research on this topic of spirituality and spiritual struggle. So the data that I'm going to show you here on this slide is from a sample of 100 Vietnam veterans who were in treatment for PTSD. Okay, so that's an important piece to keep in mind. This is not a representative sample of Vietnam veterans. These are Vietnam veterans who were in treatment for PTSD. Among those veterans, he found that nearly 60% reported that they had abandoned their religious faith during war. Nearly 60% saying that, and nearly 80% reporting that they had difficulty reconciling their beliefs with traumatic war zone events. So again, we're not using the language of moral injury here, but we're seeing that there's something for many veterans, especially those who've experienced traumas, that is particularly troubling on an existential level, on a religious level, on a spiritual level for many veterans. Kent and Joe Currier have also done work with these OEF veterans, again, are more recent veterans or post 9/11 veterans, where they've compared a sample of those veterans to the general population. So their sample of these veterans, again, these are post 9/11 veterans who were in treatment for PTSD, so veterans who'd experienced traumas. They were all men, and so the general population sample that they compared to was all male and was also adjusted for the age characteristics, so trying to make an apples to apples comparison between these two different populations. And what you can see on this graph here, the reddish bar there represents the post 9/11 veterans or our recent veterans, and the yellow bar represents the general population. So you can see that veterans were much more likely to report wondering whether God has abandoned them, over 50% reporting that, and over 50% feeling that God is punishing them for their sins or their lack of spirituality. And you can see those rates are 2 to 3 times higher than what we see in the general population, so much higher rates there. They also asked a number of additional questions, and I want to point out on this slide here, the bottom label here is important. So this is the percent that we're answering seldom or never. All right. So this is this graph here is essentially showing the percentage of folks who disagreed, right, with these statements. And what you can see is that around 50% of the veterans, again, that's the dark red bar, don't know whether God forgives them. Over 70% report that they've not been able to forgive those who have hurt them, and 80% report that they've not forgiven themselves for things that they've done wrong. And again, you can see that those rates are much higher than the general population, 3 to 4 times higher than what we see in the general population. Kent Drescher and Joe Currier and colleagues have looked at a variety of different ways, both in Vietnam era veterans and in our Iraq and Afghanistan era veterans, and compared them to their demographically matched peers, and found, and I kind of hesitate to use this terminology, but found, what we might label as weaker spirituality, different ways to sort of talk about that, but that is consistent across a range of different dimensions, whether we're looking at daily spiritual experiences or private practices, things like prayer or scripture reading, organizational religiousness, right, going to church, going to synagogue or mosque, whatever it may be, experiences of forgiveness, use of positive religious coping, connection with values. So across a range of these domains, consistently finding, however, these different measures are tapping into these things, weaker or damaged spirituality. Again, different ways to kind of name that, but among veterans compared to non-veterans in the population. Within VA, and again, so this is kind of preliminary indications before we were using the moral injury terminology. There was a study that was done, it's getting close to 2 decades now, by a couple of researchers, Fontana and Rosenheck at the New Haven VA Medical Center, where they asked this question: why do veterans with PTSD turn to the VA? Why do they come to our healthcare system? And as a clinical psychologist, the first answer that comes to mind is, well, their PTSD symptomatology probably got really bad, right? They were experiencing more nightmares, more hypervigilance and avoidance, and all these kind of things, and their symptoms just got to a point where they felt like, I need to get care for this, so I'm going to turn to the VA. Or maybe it's that they were really socially isolated and they had these symptoms, but really didn't have anybody else to turn to, so they came to the VA. Those things are important and they do affect help-seeking behavior. But what Fontana and Rosenheck found in their research, and I've highlighted just a piece of their article here in red. I'll just read the red part here. What they found was that a primary motivation of veterans' continuing pursuit of treatment is their search for a meaning and purpose to their traumatic experiences. So they actually found that over and above PTSD symptomatology, over and above whether veterans were socially isolated or not, that this loss of meaning and purpose and a search for meaning and purpose was more important in driving help-seeking behavior, was more important in motivating veterans to actually turn to the VA to receive care. And so, from our perspective in the work that we do in VA, we're of course asking ourselves the question of, well, is our system built for this, right? If people are coming to us saying, I've lost meaning and purpose and I'm looking for that, are we addressing that? So a lot of what we've done is tried to intentionally integrate chaplain and mental health services to target some of these things. I don't think that's the only answer, but I do think at the very least, it's something within our healthcare systems that we should be looking to do. Okay. So with some of the remainder of our time before the break, I want to start talking about this notion of different iterations on moral injury, providing you with some definitions of moral injury to date, distinguishing it some from PTSD, and then thinking a little bit about kind of the utility of moral injury for different constituencies. And then hopefully we'll have a little bit of time for some Q&A before we go to the break. Okay, so what is it? How has moral injury been defined to date? I'm going to give you 2 definitions on the screen here. There are more definitions that have been proposed, but really the 2 definitions that I'm showing you here have driven the thinking and the conceptualization of moral injury and the approaches to intervention more so than anything else. So this first definition comes from the psychiatrist Jonathan Shea, whose work on moral injury really came out of lots of work that he did as a psychiatrist for years with Vietnam era veterans. I've got a couple of his books there, Achilles in Vietnam and Odysseus in America, where he begins in different ways to kind of explore this idea of moral injury, not using that term a whole lot, but starting to really develop the ideas, and they're still good books, and I'll be using an excerpt from his Achilles in Vietnam book before we finish today. at one point, and so you can see that, I've got all the different citations here for Jonathan Shea, and I should note for those of you who are interested in these citations and references that will be provided to you if you want it. I think we've got a 5-page bibliography that folks can look everything up and read through it. But Shea's definition here has 3 parts to it. So moral injury is a betrayal of what's right by someone who holds legitimate authority, such as in the military, some kind of leader, in a high stakes situation. So all 3 of those pieces, Jonathan Shea says, are necessary for this definition of moral injury. Brett Litz and colleagues in 2009 came out with a publication in Clinical Psychology Review that was really the publication that has spurred a lot of the interest that we've experienced to date around moral injury. So Shea's work was very important, informational, and foundational. Brett Litz and colleagues published more in the kind of scientific literature, and that's, I think, in part why we've started to see a lot of the research going on now on moral injury in the way that it has. And so he and colleagues, you can see there, define moral injury as the psychological, biological, spiritual, behavioral, and social impact of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. I know that's kind of wordy, but hopefully you can see a little bit of the overlap with these definitions, but also some of the differences. So the key things that I really want to point out here, because these definitions have influenced a lot of the way, as I was just noting, that moral injury has been thought of, and interventions for moral injury over the years. With this definition from Shea, there's really this focus on betrayal and someone else who's in a position of authority in a high stakes situation. So you can think of kind of prototypical examples in Vietnam where My Lai massacre or something like that. Somebody in a position of authority essentially influencing you to do something that goes against your moral code, right? So it's that kind of a betrayal, feeling betrayed in that way. Whereas this definition from Litz is more about a sense of transgression. That can be a transgression, that you witnessed, that somebody else did, but there's importantly this part in there about perpetrating or failing to prevent, something that I have agency, a transgression that I have agency. I feel like I did something wrong, right? I transgressed a deeply held moral belief or expectation that I have of myself. So certainly you could imagine how, one experience of moral injury could potentially fit both of these definitions, but they are keying in on different aspects of moral injury, and we'll continue to see how that has manifested itself as we look at measures and findings and even interventions for moral injury. What is moral injury not? You're not going to find it in the DSM. It's not a psychiatric diagnosis. It's also not post-traumatic stress disorder. I say that the folks who are interested in moral injury tend to be people who've also done a lot of work in this area of PTSD. As I was showing you some of that work that I was labeling as preliminary indications, a lot of the people who've done that work are PTSD researchers, but are folks who started to kind of pick up on these other aspects of suffering after a trauma that didn't seem to fit cleanly into this diagnosis of PTSD. So certainly post-traumatic stress disorder is related both conceptually and empirically. So when I say conceptually, it's very possible that a traumatic experience could lead both to symptoms of PTSD as well as experience of moral injury, and empirically, and I'll show some data on that, ways that individuals who have higher scores on a measure of moral injury, also have higher scores on measures of PTSD. Importantly, when we look at that empirical research, some of the things that at least we've seen in our research is that while yes, there's a correlation there, we actually see stronger correlations between PTSD and depression than we do between PTSD and moral injury. Yes, there's definitely a correlation there. And we also see a little bit stronger correlations between moral injury and depression than between moral injury and PTSD. So that suggests, yes, these things are related, but they're not the exact same construct. And you'll see a little bit more of how these things are differentiated. Importantly, for those of you who really follow all the different editions of DSM that are out there, we are on the DSM-5 now. And in the DSM-5, PTSD is no longer in the anxiety disorders section of the DSM. And so I'm going to show just a little bit of a difference here between DSM-4 and DSM-5 and how PTSD is conceptualized within each of those different versions of the DSM. So within DSM-4, PTSD consists of these 4 different criterion and is in the anxiety disorders section, along with other anxiety disorders, things like panic disorders and phobias and generalized anxiety disorders and different things. And that's important. That is important because a lot of our treatments for PTSD have targeted it as an anxiety disorder. So, for example, one of the treatments that I've done with veterans in VA is prolonged exposure. For those of you who might kind of harken back to your psychology classes, if you're not a psychologist on here and you're going, oh yeah, I kind of remember that exposure thing. They use that for anxiety, right? Like if seeing snakes gives you anxiety, then like you see pictures of a snake and it makes you anxious, but then you keep looking at the pictures and you're less anxious over time, and then you touch a snake, right? So that's sort of the idea with exposure therapies, and we use exposure therapies for all sorts of different anxiety disorders, and prolonged exposure is essentially a variant of that for PTSD, where we invite people to both come into contact with a memory of a traumatic experience, something that brings up anxiety, and to continue coming into contact with that memory so that their anxiety goes down over time, as well as out in the real world, things that remind them of a traumatic experience. You don't want to go to a crowded place, or you don't want to sit with your back to people in the restaurant or whatever it is. Engaging in those types of things, feeling the anxiety, but the more you engage in those things, the more that anxiety goes down. All right, so I've done prolonged exposure. I've seen it be efficacious. That is an approach to care that comes out of understanding PTSD as an anxiety disorder. Okay, within DSM-5, PTSD has been moved into a separate section, into this trauma and stressor-related disorders section, separate from anxiety disorders. And you can see that a lot of the criterion there are still pretty much the same. Traumatic events the same. Re-experiencing and intrusive symptoms are pretty well the same. Avoidance is still there. Hyperarousal is still there in both cases. And there is now this new criterion of negative alterations in cognition and mood. And there are more explicit mentions now of things like guilt or unjustified guilt, which were not as prominent previously in DSM-4. And so some folks have said, that's kind of gesturing in the direction of moral injury. And I think that may be true. For my part, I believe the important thing to keep in mind here is, how are these conceptualizations influencing the care that we provide? So importantly, prolonged exposure is focusing on these anxiety pieces, but it's not focusing as much on guilt or shame or your identity or how you're connected to community. Lots of these things that we know are profoundly impacted by experiences of moral injury. So I think that to me is really the bottom line. however we're conceptualizing these things, what is the care that we're providing look like? And these conceptualizations do have an influence on care. And in my perspective, I think that's where moral injury is a useful contribution as we think about yes, the care of veterans, but others who've experienced traumas, because it's bringing light to an area that we need to make sure we're attending to in the provision of care. In addition to that, from even a neurological level, so this is some research that we were able to do, brought together a data set that I had and our team had, along with a data set that Raj Mori here at the VA and Dylan's son had from work that they've done with fMRI, brain scans. And we looked at those who had high and low levels of moral injury and those who had high and low levels of PTSD. And what we found, and I'm not a neuropsychologist here, that's Raj and his team. So don't ask me really difficult neuropsychological questions. But what we did find in this research was that there was increased activity in the left inferior parietal lobe, that's that LIPL that you see there, was associated with higher scores of transgression on a measure of moral injury, and with lower scores on a measure of betrayal. We didn't see that being associated with PTSD. When we looked at PTSD, we saw different regions of the brain that were being activated. And what's interesting here is that the inferior parietal lobe is one of the regions of the brain that is associated with social cognition and moral processing. So it makes sense that that's a region that we would see, lighting up a little bit more. So I think this just lends it. There's need for more research like this that's done in a more controlled capacity and a variety of different things. But I think this is suggestive already of, there's something different going on with how we've measured PTSD and what this experience of moral injury is. I've alluded to this a little bit already, but just want to note again, as I'm talking about these definitions in the research, that this is within the literature a very new phenomenon. So this graph here is a graph I've compiled just looking at citations in PubMed, so basically research citations on the topic of moral injury. And you can see there was virtually nothing before that 2009 article from Brett Litz and colleagues. These few things that were popping up before that time, when I looked at those articles, they really had nothing to do with moral injury in the way that we're talking about it. They had other sorts of meanings, like legal meanings and stuff. But after that article in 2009, it took a little bit of time, but you can see that over time there's really been an explosion of research. In the most recent year, so I just checked that earlier this week, just from 2021 alone, just from last year alone, over 150 citations in PubMed on this topic of moral injury. So it's something that's really been gaining a lot of traction and began, and a lot of that research has been with veterans, and that's why I'm talking about that today. But there's started to be interest in looking at moral injury in other populations. So over time, about once a year, I'll do sort of this Google search, and I'm kind of interested, what are the autocomplete suggestions? There's a real scientific approach here. What are Google's autocomplete suggestions when I type in moral injury? And you can see the different dates that I've done that here. And the stuff that's popping up, more interest in thinking about moral injury in healthcare and among physicians and in medicine, in the workplace. How is it related to burnout and nurses? So this is from April of 2019, which is before the pandemic. Folks were already beginning to think about some applications in that context. Repeated it in November of 2020, and you can see, healthcare is still on there, workplace, and now COVID, right, is making an appearance. People are thinking about moral injury in relation to COVID. And then I just did the search again earlier this week, and we still see a number of those same things on here, healthcare and burnout and nursing. So real interest in moral injury, even though a lot of the research has been done within veteran and military populations, a lot of interest in what does this term mean for different constituencies. And, as I've worked with it as a psychologist, but also a psychologist that works a lot with chaplains and with clergy and works in community contexts, I've seen that this term can have a lot of different utility for different constituencies. So I've got, kind of that image here of these blindfolded individuals all sort of kind of feeling out this elephant, right? Nobody sees the full elephant, and they're sort of going, oh, it's a spear, or it's a fan, or it's a snake, it's a rope, it's a wall, it's a tree, right? Everybody's seeing their different part of the elephant and interpreting moral injury in some different ways. And I think there's value to that. And it's important that we be talking with each other and not staying in our silo and going, yep, it's definitely just a spear, right? Or it's definitely just a fan. We need to do those things that we bring to the table as professionals, and we need to be talking with one another about these things. So, as I've been alluding to from a mental health perspective, I think that moral injury has been very helpful in causing us to be self-critical and self-reflective about some of our treatments for PTSD, right? So that the moral injury literature very much kind of developed out of mental health in relation to PTSD. These folks that I was showing you, some of their research are PTSD researchers, and it's causing us to go, wait a minute, we need to be attending to other experiences that are there too, not just